Varcarolis, Psychiatric and Mental Health Nursing, 8th edition, Chapter 27, Anger, Aggression, and Violence. Key terms: aggression, anger, de-escalation techniques, restraint, seclusion, trauma-informed care, validation therapy, violence. Anger, aggression, and violence are the subject of daily news headlines. Due to the scope and prevalence of the problem, you may notice an expanding list of terminology used to describe specific types of aggression. Road rage is a dangerous habit rampant in high-stress, industrialized societies and is accompanied by cursing, offensive gestures, and cutting others off while driving. Air rage is objectionable behavior, aggressive utterances, threats, and violence within the confines of an aircraft. Desk rage includes lashing out while at work. Hospitals, as 24-hour-a-day high-stress environments, have even earned a term for their own brand of confrontation: ward rage. Clinical picture. Anger is an emotional response to frustration of desires, a threat to one's needs, emotional or physical, or a challenge. It is a normal emotion that can even be positive when it is expressed in a healthy way. Once anger is acknowledged, channeling anger into productive pursuits such as exercise, art, or cleaning out a closet is healthy. Anger can also be a motivator to try harder or an aid in survival when fighting is the last and only resort. Aggression is an action or behavior that results in a verbal or physical attack. Aggression tends to be used synonymously with violence. However, aggression is not always inappropriate and is sometimes necessary for self-protection. On the other hand, violence is always an objectionable act that involves intentional use of force that results in, or has the potential to result in, injury to another person. Coping with a person's anger is a challenge. Effective nursing intervention becomes more difficult when the anger becomes personal and is directed at the nurse or nursing student. Nursing intervention should, ideally, begin before anger and aggression become a problem. Anxiety is often the precipitant for negative feelings and behaviors. Assessing and responding to this anxiety can have extremely positive returns. Refer to Chapter 15 for interventions to reduce anxiety before it becomes a crisis. Epidemiology. The Centers for Disease Control and Prevention reported almost 60,000 violence-related injuries in 2014. It is likely that you will need to manage violent behavior at some point in your career. Nurses are frequent targets of violence because they have the most direct patient contact. Violence can occur anywhere in the hospital, but is most frequent in the emergency rooms. Psychiatric units, geriatric units, and intensive care units are also overrepresented in patient and patient's significant others attacks. Examples of attacks on nurses include a Texas outpatient surgery center where the son of a patient accused staff of trying to kill his mother. He fatally stabbed a nurse who was trying to protect other patients, 2013. A Maine psychiatric hospital where a patient with a chair injured a nurse's face and head. Another angry patient on the same unit stabbed a nurse with a pen, 2014. A Texas emergency room where a woman became enraged over being denied pain medication. When the nurse handed the patient a clipboard with discharge instructions, the patient struck the nurse in the face with the clipboard, 2016. Comorbidity. A great deal of research has been done on aggression and violence in persons with post-traumatic stress disorders and substance use disorders. Johnson et al. Found that persons with bipolar disorder have difficulty with anger and aggression even during remission. Anger and hostility have effects on physical well-being. They are risk factors for hypertension and cardiovascular disease, including myocardial infarctions and ischemic strokes. Expression of anger in adults predicted a higher prevalence of metabolic syndrome. Etiology, biological factors, genetics. Some individuals are biologically more predisposed than others to respond to life events with irritability, easy frustration, and anger. This predisposition may be a function of genetics or of neurological development that occurs in the context of certain infant and childhood environments. Individuals who have a history of aggression have been shown to be more acutely aware of subtle facial cues of anger. Neurobiological. Neurological conditions are associated with anger and aggression. Brain tumors, Alzheimer's disease, temporal lobe epilepsy, and traumatic injury to certain parts of the brain result in changes to personality that could include increased violence. Many patients with brain injury have severe behavior disorders, including aggressiveness, that disrupt their lives. One area of the brain associated with aggression is the limbic system. It is located just beneath the cerebrum on both sides of the thalamus. It is responsible for combining higher mental functions and primitive emotions into one system, learning, and the formation of memories. Important structures within this system include the amygdala and the hippocampus. The amygdala is the emotional center of the brain. It helps evaluate the emotional content of our experiences. It helps the brain to recognize potential threats and whether to activate the fight or flight response. In animal studies, stimulation of the amygdala produces rage responses, whereas lesions in the same structure result in meekness. In humans, men with lower amygdala volume exhibit higher levels of aggression from childhood to adulthood. The hippocampus lies in close proximity to the amygdala and connects to it. The seahorse-shaped structure is essential to the formation of new memories. Research demonstrates that aggressive behavior may result in the formation of new cells within the hippocampus. Male mice that repeatedly won fights with other mice became more aggressive and anxious. This study demonstrates that getting angry may make a person angrier, and the cycle continues. The especially large prefrontal cortex in humans also plays an important role in aggressive behavior. This area of the brain is responsible for executive function. Executive function allows us to distinguish between good and bad, consequences of actions, goal-directed behavior, and suppressing socially unacceptable activities. According to Seaver, aggressive acts triggered by anger-provoking stimuli are the result of a failure of the control systems in the prefrontal cortex. Individuals with antisocial personality disorder have been shown to have less gray matter in their prefrontal cortexes. Neurotransmitters, especially serotonin, dopamine, and GABA, play a vital role in anger and aggression. Serotonin can both inhibit and stimulate aggressive behavior, depending on the part of the brain being measured. Dopamine's impact on reward-seeking behavior may increase aggression. Like serotonin, dopamine can sometimes enhance aggression and sometimes reduce impulsivity that leads to aggression. GABA, the main inhibitory neurotransmitter, may reduce aggressiveness. Its absence may increase impulsivity and aggressive responses. Psychological factors. Sigmund Freud wrote in Civilization and Its Discontents that the conflict between sexual needs and societal norms was the source of mankind's dissatisfaction, aggression, hostility, and ultimately violence. Menninger asserted that the struggle for control over our lives is a fundamental drive in every person. If that control is threatened, we experience trauma, and it is from the trauma that anger, aggression, and violence may originate. Early behaviorists believed that emotions, including anger, were learned responses to environmental stimuli, such as Skinner, 1953. The stimulus is often a perceived threat, and this perception leads to the emotional and physiological arousal necessary to take action. Although the threat is usually understood as an alert to physical danger, Beck, 1976, noted that other threats to areas such as values, beliefs, and moral code could also lead to danger. For example, clinic patients kept waiting for long periods of time without explanation may perceive this wait as a lack of respect. When the initial appraisal is followed by thoughts such as, they have no right to treat me this way, I am a person too, anger may escalate and violence is possible. Patients less predisposed to anger might interpret the wait as a sign that the clinic is busy. These patients might be frustrated by the situation. However, in the absence of anger, they might be proactive and ask how much longer the wait is likely to be, find distractions in the environment, or reschedule the appointment. Social learning researchers demonstrated that children learn aggression by observing and imitating behaviors of others, especially if that behavior is rewarded. Bandura, 1973. Thus, children who watch television violence or experience violence in the home learn aggressive ways of resolving problems. Not only is television violence portrayed as an option for resolving conflict, but most of those violent acts do not result in negative consequences. Bullying is another less extreme form of violence that is far more prevalent and has significant consequences. Bullying is any negative activity, including teasing, kicking, hitting, and spitting, intended to bother or harm someone else. A little box here. I'm going to read that later. Application of the nursing process. Assessment. General assessment. When patients are experiencing anger, you often see it manifested behaviorally. Increased demands, irritability, frowning, redness of the face, pacing, twisting of the hands, or clenching and unclenching of the fists are all signs of irritation. Speech may either be increased in rate and volume or may be slowed, pointed, and quiet. You should address any change in behavior from what is typical for the patient. Box 27.1 identifies signs and symptoms that indicate the risk of escalating anger leading to aggressive behavior. Box 27.1, predictors of violence. Hyperactivity, most important predictor of imminent violence, e.g. pacing and restlessness. Increasing anxiety and tension, clenched jaw or fist, rigid posture, fixed or tense facial expression, mumbling to self. Patient may have shortness of breath, sweating, and rapid pulse. Verbal abuse, profanity and argumentativeness. Loud voice, change of pitch, or very soft voice, forcing others to strain to hear. Stone silence, intense eye contact or avoidance of eye contact. Recent acts of violence, including property violence, alcohol or drug intoxication. Possession of a weapon or object that may be used as a weapon. A fork, a knife, or a rock. Isolation that is uncharacteristic. Milieu characteristics conducive to violence are overcrowding staff and experience, provocative or controlling staff, poor limit setting, arbitrary revocation of privileges. Fascinating. It's also important to assess the patient's history of aggression or violence. Most of our reactions to stimuli come from our previous experiences. Therefore, identifying patient triggers is essential. Initial and ongoing assessment of the patient can reveal problems before they escalate to anger and aggression. Such assessment also leads directly to the appropriate nursing diagnosis and intervention. Health policy, workplace violence. Workplace violence has been occurring in the healthcare setting for decades. The American Nurse Association's Code of Ethics for Nursing with Interpretive Statements states that nurses are required to, quote, create an ethical environment and culture of civility and kindness, treating colleagues, coworkers, employees, students, and others with dignity and respect. In 2015, the ANA wrote a position statement on incivility, bullying, and workplace violence. They encourage collaboration of registered nurses and employers to create a culture of respect. Use of evidence-based strategies that prevent incivility, bullying, and workplace violence was also suggested. Other recommendations for nurses include establishing an agreed-upon code word they feel threatened, developing a plan to address incivility and bullying, and becoming advocates for identification and prevention of incivility and bullying. Trauma-informed care is an older concept of providing care that has been recently reintroduced. It is based on a notion that disruptive patients often have stories that include violence and victimization. These traumatic histories can impede patients' ability to self-soothe, result in negative coping responses, and create a vulnerability to coercive interventions, such as restraint by staff. Trauma-informed care focuses on the patient's past experience of violence or trauma and on the role these experiences currently play in their lives. Careful assessment can reduce the potential for violence. In a study conducted in the New York State Psychiatric Institute, patients filled out a questionnaire that identified things that made them upset, how they responded to being upset, and how they wanted to be treated when they became upset. Examples of how they wanted to be treated included talking with them and allowing them time out alone. Making use of the patient's suggestions resulted in a decreased amount of time in restraints and seclusion and a reduction in the number of fights and assaults on the unit. Evidence-based practice. There's a little case study here. We're going to read that later. Self-assessment. Like patients, nurses have their own histories. The nurse's ability to intervene effectively depends on self-awareness of the strengths, needs, concerns, and vulnerabilities. Without this awareness, nursing interventions can end up being impulsive or emotion-based responses. Self-awareness includes recognizing choice of words and tone of voice, as well as nonverbal communication through body posture and facial expressions. Assessment guidelines, anger and aggression. Got a little box here. General risk identification includes assessing for the following. 1. A history of violence is the single best predictor of future violence. 2 patients who are delusional, hyperactive, impulsive, or predisposed to irritability are at a higher risk for violence. 3 major factors associated with violence can be assessed with these questions. Does the patient have a wish or intent to harm? Does the patient have a plan? Does the patient have the means available to carry out the plan? Does the patient have demographic risk factors? Male gender, age 14 to 24 years, low socioeconomic status, inadequate support system, and prison time. 4. Aggression by patients occurs most often in the context of limit setting by the nurse. 5. History of limited coping skills, including lack of assertiveness or use of intimidation, indicates a higher risk of using violence. Diagnosis. Patients may have coping skills that are adequate for day-to-day events, but may be overwhelmed by the stresses of illness or hospitalization. Other patients may have a pattern of maladaptive coping that is marginally effective and coping strategies that may increase the possibility of anger and aggression. When the nursing assessment identifies potential for anger and aggression, risk for other directed violence, risk for self-directed violence, ineffective coping, overwhelmed or maladaptive, stress overload, and impaired impulse control are important nursing diagnoses to consider. Outcome identification. Clearly defined outcome criteria are important for identifying the behaviors that staff can encourage if their interventions have been successful. The nursing outcomes classification outlines specific outcome criteria for use with angry and aggressive patients. Table 27.1 identifies signs and symptoms commonly experienced with anger and aggression, offers potential nursing diagnoses, and suggests outcomes. That's a big table. We can take a look at that later. Planning. Planning interventions requires a sound assessment, including patient history, previous acts of violence, comorbid disorders, past triggers, and present coping skills. Patients need to be willing and able to learn alternative and non-violent ways of handling angry feelings. Implementation. Ideally, intervention begins before any sign of escalation. It is important to develop a relationship of trust with the patient by having numerous brief, non-threatening, non-directive interactions, like talking about the weather, sports, or something of interest to the patient, in settings in which staff can reasonably expect episodes of patient anger and aggression. Regular teaching and practice of verbal and nonverbal interventions are essential. This fosters nurses' increased confidence in their own abilities and those of coworkers. Psychosocial interventions. If you can attempt to determine what the patient is feeling, you have already begun to intervene. Frequently, you can accomplish this by telling the patient that you are concerned and want to listen. It is essential to acknowledge the patient's needs, regardless of whether the expressed needs are rational or possible to meet. It is equally as important to clearly state your expectations for the patient's behavior. I expect that you will stay in control. However, patient behavior may escalate quickly, or the patient may mask early signs of distress. Nurses may be distracted and miss those early signs. Some agitated patients may be so acutely upset that they do not respond to early nursing interventions. In these situations, the problem with anger may not be resolved before the risk for violence arises. Pharmacological intervention, seclusion, or restraint may be necessary to ensure the safety of patients and staff. Approach the patient in a controlled, non-threatening, and caring manner. If you are experiencing fear, you may find that this is quite challenging. Maintaining a calm exterior while your interior is in an upheaval requires considerable self-discipline and will come with experience. Patients who are at risk for violence need much more personal space than those who are not. Allowing the patient enough space so that you are perceived as less of a threat. Always stay about 1 foot farther than the patient can reach with arms or legs. Be sure you have left yourself an escape route if necessary. That is, make sure the patient is not between you and the door. While you are giving the patient space, the patient may be invading your space with verbal abuse and profanity. As uncomfortable as this may be to you, you cannot take the patient's words personally or respond in kind. It is also important not to end the conversation because of the patient's verbal abusiveness or to forbid the patient from communicating in this way. When anger is escalating, a patient's ability to process decreases. It is important to speak to the patient slowly and in short sentences using a low and calm voice. Never yell, but continue to model controlled behavior. Use open-ended statements and questions such as, "You think people are treating you unfairly?" rather than challenging statements such as, "What is going on right now?" Avoid ending statements with "okay," because it may give the impression that choices exist. Find out what is behind the angry feelings and behaviors. Identify the patient's options and encourage the individual to assume responsibility for choices made. You may want to give two options such as, "Do you want to go to your room or to the quiet room for a while?" This approach decreases the sense of powerlessness that often precipitates violence. Pay close attention to the environment. Choose a quiet place to talk to the patient, but one that is visible to staff. This is most beneficial in helping a patient regain control. Staff should know you are working with the patient, keep an eye on the interaction, and be prepared to intervene if the situation escalates. At this point, move other patients away and, as much as possible, remove any object in the area that could be used as a weapon. Considerations for staff safety. There are 6 basic considerations for ensuring safety. 1. Avoid wearing dangling earrings, necklaces, and scarves in acute care environments. The patient may become focused on these and grab at them, causing serious injury. Ensure that there is enough staff for backup. 2. Only one person should talk to the patient, but staff need to maintain an unobtrusive presence in case the situation escalates. 3. Always know the layout of the area. Correct placement of furniture and elimination of obstacles or hazards are important to prevent injury if the patient requires physical interventions. 4. Do not stand directly in front of the patient or in front of the doorway. The patient may consider this position as confrontational. It is better to stand off to the side and encourage the patient to have a seat. 5. If a patient's behavior begins to escalate, provide feedback. You seem to be very upset. Such an observation allows exploration of the patient's feelings and may lead to de-escalation of the situation. 6. Avoid confrontation with the patient, either through verbal means or through a show of support with security guards. Verbal confrontation and discussion of the incident must occur when the patient is calm. Show of force by security guards may serve to escalate the patient's behavior. Security personnel are better kept in the background until they are needed to assist. Box 27.2 lists some principles underlying de-escalation techniques. Box 27.2. Maintain the patient's self-esteem and dignity. Maintain calmness, your own and the patient's. Assess the patient and the situation. Identify stressors and stress indicators. Respond as early as possible. Use a calm, clear tone of voice. Invest time. Remain honest. Determine what the patient considers to be needed. Identify goals. Avoid invading personal space. In times of high anxiety, personal space increases. Avoid arguing. Give several clear options. Use genuineness and empathy. Be assertive, not aggressive. Do not take chances. Maintain personal safety. Pharmacological interventions. When a patient is showing increased signs of symptoms of anxiety or agitation, it's perfectly appropriate to offer the patient an as-needed medication to alleviate symptoms. When used in conjunction with psychosocial interventions and de-escalation techniques, this can prevent an aggressive or violent incident. Anti-anxiety agents and antipsychotics are used in the treatment of acute symptoms of anger and aggression. These agents, their form of delivery, and considerations are in Table 27.2. It's a big table, a lot of stuff in there. We can look at that later. During aggressive or violent incidents, Haldol has historically been the most widely used first-gen antipsychotic. Second-gen antipsychotics such as Zyprexa and Geodon have become more common due to reduced side effects compared with first-gen drugs. The dissolving tablet version of Zydis was introduced recently as an alternative to injectable medication, with effects being seen within 10 minutes of administration. An inhaled first-gen antipsychotic, Adasuve, has been approved for use in limited settings due to the potential for a fatal bronchospasm. Anti-anxiety benzos such as Ativan may reduce the amount of antipsychotic that is needed to control agitation. You may also have orders to administer a combination of antipsychotic and benzo intramuscularly. Diphenhydramine or Cogentin added to the injection reduces EPS side effects. It is a nurse's role to assess for appropriateness of as-needed medications. The nurse also educates the patients about the medication, the reason it is being given, and the potential side effects of the medication, even if the patient is out of control. The long-term treatment of anger, aggression, and violence is based on treating the underlying psychiatric disorder. SSRIs, lithium, anticonvulsants, benzodiazepines, second-gen antipsychotics, and beta blockers are all used successfully for specific patient populations. Anger and aggression related to ADD and ADHD may be reduced through the use of psychostimulants. Table 27.3 gives an overview of the drugs used to treat chronic aggression. Health teaching and health promotion. One of the most important roles a nurse plays in a patient's recovery is that of role model and educator. You can model appropriate responses and ways to cope with anger, teach patients a variety of methods to appropriately express anger, and educate patients regarding coping mechanisms, de-escalation techniques, and self-soothing skills to manage behavior. It is also helpful to assist the patient in identifying triggers for angry or aggressive behavior. One method that can be used if the patient is not out of control is a do-over. The patient who responds inappropriately can try again to respond in a more appropriate way while being coached by the nurse. Interest in using alternative interventions such as forgiveness and compassion in healthy patients has been gaining interest. Nurses may introduce these concepts and educate the patient on how to incorporate them into their lives. Teamwork and safety. A multidisciplinary approach is important for all patients, but especially for a patient with behavioral issues. All team members must implement a plan of care and execute that plan. During team meetings, staff should discuss intervention strategies. The plan for discharge with appropriate follow-up, possibly with an anger management course, must be put into place. The consistency of intervention among all team members is key to the patient's success. A thorough consideration of the environment is important when considering anger and aggression on the unit. It is important to be proactive and not reactive. It is hard to imagine how the stimulation of a psychiatric unit might be experienced by someone whose anxiety is extremely high or who is delusional or confused. If the patient has enough control, sometimes simply taking a time out in his or her own room is sufficient. A multisensory room is another form of timeout. It is also known as snoezelen, named partly from the Dutch word for dozing. This quiet room is partially lit, has relaxing music available, and comfortable furniture and soft pillows. It promotes feelings of security and safety. Realize that behavior rarely occurs in a vacuum. The nurse must examine the milieu as a whole and identify the stressors patients have to deal with, especially patients who have antisocial personality disorder. These individuals have a tendency to create havoc and make it appear that another patient is at fault, either for their own pleasure or for their own purposes, e.g. escaping the unit or getting into the medication room. So even while dealing with an incident, staff must be aware of what could be happening in the surrounding environment. Use of seclusion or restraints. Occasionally, despite numerous interventions, a patient will become violent and require seclusion or restraint. When this happens, it is essential to have an organized approach to the seclusion or restraint. Legally, most courts hold that seclusion and restraint be implemented only when a patient creates a risk of harm to self or others, and no less restrictive alternative is available. These measures should never be used for punishment or for the convenience of staff. Seclusion or physical restraint is used only for alternative interventions have been tried. These interventions include verbal interventions, offering an as-needed medication, decreasing sensory stimulation, presence of a significant other, frequent observation, or one-on-one observation of the patient. According to the U.S. Department of Health and Human Services, seclusion refers to the involuntary confinement of a patient alone in a room or area from which the patient is physically prevented from leaving. The goal of seclusion is never punitive. Rather, the goal of seclusion is safety of the patient and others. Seclusion is less restrictive than restraint and may be helpful in reducing sensory overstimulation. Restraint is defined as any manual method, physical or mechanical device, material or equipment that immobilizes or reduces the ability of a patient to move his or her arms, legs, body, or head freely. There are several contraindications for the use of seclusion and restraint. Patients who have extremely unstable medical and psychiatric conditions are not considered safe candidates for these treatments. Chronic obstructive pulmonary disease, spinal injury, seizure disorder, and pregnancy are examples of contraindicated problems. Delirium or dementia may make seclusion and restraint intolerable due to the absence of stimulation. These restrictive measures should be avoided in patients who are overtly suicidal and those who require monitoring for severe drug interactions or overdoses. A patient may not be held in seclusion or restraint without an order from a licensed practitioner, although in emergency situations, the order may be received after the fact. Once in a restraint, a patient must be directly observed and formally assessed at frequent regular intervals for a level of awareness, level of activity, safety within the restraints, hydration, toileting needs, nutrition, and comfort. Licensing and accreditation agencies mandate how frequently you need to observe patients in seclusion and restraint. Each team member is trained in the correct use of seclusion and restraint. The team should be organized before approaching the patient so that there is a clear leader and each team member knows his or her individual responsibility. The team leader is the only person talking to the patient to decrease stimuli. The patient must be given every opportunity to regain control so that the least restrictive method can be used. If restraints are to be used, the patient is informed at this point of the team's intent and the reason for the actions. The team remains calm and acts as quickly as possible. Once the patient is placed in seclusion or restraint, the nurse must get an order from the appropriate provider. The nurse may also get an order for medication and administer it to the patient. The team leader continues to communicate with the patient in a calm, steady voice indicating decisiveness, consistency, and control. Guidelines for the use of mechanical restraints are in Box 27.3. Box 27.3. Guidelines for use of mechanical restraint. Indications for use. To protect the patient from self-harm, to prevent the patient from assaulting others, legal requirements, multidisciplinary involvement, appropriate healthcare provider signature according to state law, patient advocate or relative notification, seclusion, restraint discontinued as soon as possible. Documentation. Patient's behavior leading to restraint seclusion. Least restrictive measures used before restraint. Interventions used and patient's response interventions. Plan of care for restraint seclusion use implemented. Ongoing evaluations by nursing staff and appropriate healthcare providers. Clinical assessments. Patient's mental status at the time of restraint. Physical examination for medical problems, possibly causing behavioral changes. Need for restraints. Observation. Staff in constant attendance. Complete written record every 15 minutes. Monitor vital signs. Assess range of movements. Observe blood flow in hands and feet. Observe that restraint is not rubbing. Provide for nutrition, hydration, and elimination. Release procedure. Patient must be allowed to follow instructions and stay in control. Termination of restraints. Debrief with patient. Restraint tips. Physical holding of a patient against will is a restraint. Force handrails up is a restraint except in seizure precautions. Keeping a patient in his or her own room by physical intervention is seclusion. Tucking sheets in so tightly patient cannot move is a restraint. Orders for seclusion restraint cannot be as needed or PRN. While the patient is in seclusion or restraint, close monitoring to determine the patient's ability to reintegrate into unit activities is mandatory. Reintegration should be gradual and geared towards the patient's ability to handle increasing amounts of stimulation. If the reintegration proves to be too much for the patient and results in increased agitation, the individual is returned to the room or another quiet area. Patients must be able to follow commands and control behaviors before reintegration can occur. Generally, a structured reintegration is the best approach. Once a patient no longer requires a locked seclusion room or restraints and is able to exercise self-control, he or she can be returned to the unit. Afterward, the patient should be observed carefully to maintain safety. In some cases, the patient may require further seclusion or restraint, for which you would have to obtain another order. Immediately after the seclusion or restraint episode, the staff must engage in debriefing with one another. Staff analysis of the episode of violence, referred to as critical incident debriefing, is crucial for a number of reasons. First, a review is necessary to ensure that quality care was provided to the patient. Staff members need to critically examine the response to the patient. Questions to be answered include the following. Could we have done anything that would have prevented the episode? If yes, then what could have been done and why was it not done in this situation? Did the team respond as a team? Were team members acting in accordance with policy and procedures of the unit? If not, why not? How do staff members feel about this patient, about the situation? Feelings of fear and anger are discussed and handled. Employee morale, productivity, use of sick time leave, transfer requests, and absenteeism are all affected by patient violence, especially if a staff member has been injured. Staff members must feel supported by their peers and by the organizational policies and procedures established to maintain a safe environment. Is there a need for additional staff education regarding how to respond to violent patients? How did the actual restraining process go? What could have been done differently? Do not focus only on whether staff members were acting like a team. If injury occurred, has it been reported and cared for? It has been shown that there is a vast underreporting of violence against healthcare staff. When the patient is reintegrated into the unit, discussion with the patient is an important part of the therapeutic process. Going over what occurred allows the patient to learn from the situation, to identify the stressors that precipitated the out-of-control behavior, and to plan alternative ways of responding to those stressors in the future. The nurse must provide documentation in situations in which violence was either averted or actually occurred, including the following. Behaviors that occurred as the patient was escalating, nursing interventions and the patient's responses, evaluation of the interventions used, detailed description of the patient's behavior during the assaultive stage, all nursing interventions used to defuse the crisis, patient's response to those interventions, observations of the patient and the interventions performed while the patient was in restraint center or seclusion, the way the patient was reintegrated into the unit milieu. Box 27.4 lists selected nursing intervention classifications for anger control assistance. Let's take a closer look at intervening in different settings with patients who are exhibiting anger and have the potential for aggression and violence. Box 27.4. NIC interventions for anger control assistance. Establish basic trust and rapport with the patient. Use calm, reassuring approach. Determine appropriate behavioral expectations for expression of anger, giving patients level of cognitive and physical functioning. Limit access to frustrating situations until patient is able to express anger in an adaptive manner. Encourage patient to seek assistance from nursing staff or responsible others during periods of increasing tension. Monitor potential for inappropriate aggression and intervene before its expression. Prevent physical harm if anger is directed at self or others, e.g., restrain and remove potential weapons. Provide reassurance to patient that nursing staff will intervene to prevent patient from losing control. Use external controls, e.g., physical or manual restraint, timeouts, and seclusion, as needed to calm patient who is expressing anger in a maladaptive manner. Caring for patients in general hospital settings. Patients with healthy coping who are overwhelmed. A patient loses autonomy and control when hospitalized, which can cause a great deal of related distress. When this stress is combined with the uncertainty of illness, a patient may respond in ways that are not usual for him or her. A careful nursing assessment with history and information from family members helps evaluate whether a patient's anger is a usual or an unusual way of managing stress. Interventions for patients whose usual coping strategies are healthy involve finding ways to reestablish or substitute similar means of dealing with the hospitalization. This problem solving occurs in collaboration with the patient In interactions that demonstrate the nurse acknowledges the patient's distress, validates it as understandable under the circumstances, and indicates a willingness to search for solutions. Validation includes making an apology to the patient when appropriate, such as when a promised intervention, e.g. changing a dressing by a certain time, has not been delivered, or sympathizing with the patient about the horrible food by assisting with menu selections. Patients who have become angry may be unable to moderate this emotion enough to problem solve with their nurses. Others may be unable to communicate the source of their anger. Often, the nurse, knowing the patient and the context of the anger, can make an accurate guess at what feeling is behind the anger. Naming this feeling can lead to dissipating of the anger, help the patient to feel understood, and lead to a calmer discussion of the distress. Some of the feelings that can precipitate anger are listed in box 27.5. The following vignette provides an example of nursing interventions that are helpful in dissipating anger in a hospital situation. We're going to read that later. Box 27.5. Feelings that may precipitate anger. Discounted, embarrassed, frightened, found out, guilty, humiliated, hurt, ignored, inadequate, insecure, unheard, out of control of the situation, rejected, threatened, tired, vulnerable. Patients with marginal coping skills. Patients whose coping skills were marginal before hospitalization need a different set of interventions than those with basically healthy ways of coping. Patients with maladaptive coping are poorly equipped to use alternatives when their initial attempts to cope are unsuccessful or are inappropriate. Such patients frequently manifest anger that moves quickly from anxiety to aggression. For some people, anger and intimidation are primary strategies used to obtain their short-term goals of feeling of control or mastery. For others, the anger occurs when limited or primitive attempts at coping are unsuccessful and alternatives are unknown. For these patients, anger and violence are particular risks in inpatient settings. This is especially true for hospitalized patients with chemical dependence who may be anxious about being cut off from their substance of choice. They may have well-founded concerns that any physical pain will be inadequately addressed. Many patients with marginal coping also have personality styles that externalize blame. That is, they see the source of their discomfort and anxiety as being outside themselves. Relief must therefore also come from an outside source, e.g., the nurse or medication. Interventions begin with attempts to understand and meet the patient's needs. For instance, you can moderate baseline anxiety by the provision of comfort items before they are requested, e.g., decaffeinated coffee, deck of cards. This can build rapport and act symbolically to reassure. Reducing ambiguity or uncertainty can also help minimize anxiety. This strategy includes clear and concrete communication. Nurses should be clear about what is within the nurse's power to provide, such as, I can't order Vicodin for you, but I will talk with your nurse practitioner about what we can do. Most hospitals have some sort of withdrawal protocol assuring the patient that he or she will not go through withdrawal without medication. This can be very anxiety relieving if the patient has a chemical dependency problem. Intervention for anxiety might also include the use of distractions such as magazines, action comics, and video games. Generally, distractions that are colorful and do not require sustained attention work best, although this varies according to the patient's interests and abilities. Finally, patients with high level of baseline anxiety and limited coping skills are helped when their interactions with the treatment team are predictable. This may include speaking with a physician at a specific time each day and consistency in nursing assignments. Individuals from outside the unit, such as a chaplain or a volunteer, may help by giving the patient more attention. Because these patients have limited coping skills, once anxiety is moderated, nursing interventions include teaching alternative behaviors and strategies. For patients who externalize blame, it is best to precede such teaching by a gentle challenge. The challenge serves to engage the patient's interest in teaching that might otherwise be seen as irrelevant. This intervention is also important in that the nurse has 1. Avoided a punitive or demeaning response that might have fueled escalation of the patient's anger, 2. Taught a number of strategies, and 3. Provided the patient with choices and thus more control. Often others communicate anger through long-term verbal abuse. If attempts to teach alternatives have not been successful, you can use 3 interventions. 1. The first is to leave the room as soon as verbal abuse begins. The patient can be informed that the nurse will return in a specific amount of time when the situation is calmer. A matter-of-fact, neutral manner is important because fear, indignation, and arguing are gratifying to many verbally abusive patients. Alternatively, if the nurse is in the middle of a procedure and cannot leave immediately, the nurse can break off conversation and eye contact, completing the procedure quickly and matter-of-factly before leaving the room. The nurse avoids chastising, threatening, or responding punitively to the patient. 2. Withdrawal of attention of verbal abuse is successful only if a second intervention is also used. This step requires attending positively to, and thus reinforcing, non-abusive communication by the patient. Interventions can include discussing non-illness related topics, responding to requests, and providing emotional support. 3. Patients who are verbally abusive may respond best to the predictability of routines such as scheduled contacts with a nurse, e.g. every 30 or 60 minutes. Use of such contacts provides nursing attention that is not contingent on the patient's behavior and therefore does not reinforce the abuse. Of course, the patient's illness or injury may sometimes require nursing visits for assessment or intervention outside the scheduled contact times. These visits can be carried out in a calm, brief, matter-of-fact manner. Implementing appropriate interventions can be difficult when the nurse is feeling threatened. Remaining matter-of-fact with patients who habitually use anger and intimidation can be difficult. These patients are often skillful at making personal and pointed statements. It is important to remember that patients do not know their nurses personally and thus have no basis on which they can make judgments. Nurses can also vent their own responses elsewhere with other staff or family members while maintaining confidentiality or by critical incident debriefing. There's a couple more of these little vignettes on this page, and I'm not going to read them. Caring for patients in inpatient psychiatric settings. It is important to know that not all psychiatric patients are violence-prone, and aggression appears to be correlated less with certain illnesses than with certain patient characteristics. The 2 most significant predictors of violence are a history of violence and a history of impulsivity. Situational factors contribute to patient anger and aggression. For instance, feelings of vulnerability and powerlessness resulting from trying to come to grips with depersonalized hospital routines, intrusive procedures, and restrictions on freedom can lead to anger and possibly aggression. Additional causes of patients' anger include 1. Unrealistic expectations that their nurses will be angels of mercy. 2. The feeling that care providers are ignoring their physical and psychological needs. And 3. The feeling that healthcare workers fail to recognize the uniqueness and wholeness of the patient. If staff can identify patients who have a potential for violence, early intervention becomes possible. Nurses can work with these patients to recognize early signs of anger and can teach them strategies to manage the anger and prevent aggression. Caring for patients with cognitive deficits. Patients with cognitive deficits are particularly at risk for acting aggressively. Such deficits may result from delirium, dementias, Alzheimer's disease, multi-infarct dementia, or brain injury. Traditional approaches to disorientation and to the agitation it can cause have relied heavily on reality orientation and medication. Reality orientation consists of providing the correct information to the patient about place, date, and current life circumstances. For many patients, this is comforting because it reminds them of pertinent information and helps them feel grounded. For others, reality orientation does not work. Because of their cognitive disorder, they can no longer enter into our reality. They become frightened and more agitated and may become aggressive. Orientation aids such as calendar and a clock can provide easy reference and increased autonomy. Such aids must be prominent and easily read by patients with diminished eyesight. Sedating medication may calm agitation, but the risks often outweigh the benefits. Sedation only further clouds a patient's sensorium, which makes disorientation worse and increases the risk of falls and injuries. It is better to examine alternative interventions. Typically, patients experiencing delirium will be in and out of reality. At times they will appear perfectly fine, and at others they will have a clouded sensorium. They will sometimes fall asleep as you are talking to them. Often, patients with delirium have visual hallucinations, commonly of children, animals, or bugs. Occasionally, they will show periods of paranoia. The best intervention for delirium is to find and treat medical cause. Next choice is to medicate the symptoms with a low-dose antipsychotic and discontinue it as the delirium clears. Patients with any clouding of the sensorium have difficulty interpreting environmental stimuli. Another set of interventions involves making the environment as simple, predictable, and comfortable as possible. Simplicity includes decreasing sensory stimuli. In the hospital, this might include placing the patient's bed away from doorways that enter onto the hall and choosing not to turn on the television. Establishing a routine of activities for each day and displaying the day's schedule prominently in the patient's room can provide predictability. You can enhance the comfort of the patient by providing similar photographs and objects from home. The availability of a rocking chair can provide a rhythmic source of self-soothing. Sometimes the patient with a cognitive disorder experiences such severe agitation and aggression that it is referred to as a catastrophic reaction. The patient may scream, strike out, or cry because of overwhelming fear. Adopting a calm and unhurried manner is the best approach to take with such a patient. To respond effectively to episodes of agitation, it is crucial to identify the antecedents, which preceded the episode, and the consequences of such episodes. Once antecedents are understood, interventions are often obvious. Another vignette, won't read it. Patients who misperceive their setting or life situation can use validation therapy to calm themselves. Some disoriented older patients believe that they are young and feel the need to return to important tasks that were a significant part of those earlier years. For example, a woman may insist that she must go home and take care of her babies. Telling the patient that her babies have grown up and there is no home to return to is not only cruel, but non-therapeutic and will result in increased agitation. It is often more helpful to reflect back to the patient the feelings behind her demand and to show understanding and concern for her worry. Rather than attempting to reorient the patient, the nurse should ask the patient to further describe the setting or situation reported to be a problem, e.g., the need to return home. During the conversation, the nurse can comment on what appears to be underlying the patient's distress, thus validating it. In the earlier example, the woman who believes that she needs to return home to care for her children is asked to tell the nurse more about her children. The nurse may know that the patient misses her children and that the current setting gets lonely at times. Nurse: Miss Green, you miss your children, and this can be a lonely place. As the nurse shows interest in aspects of the patient's life, the nurse establishes himself or herself as a safe, understanding person. In turn, the patient often becomes calmer and more open to redirection. As patients reminisce in this fashion, they often bring themselves into the present. Patient: Of course, they're all grown up and doing well on their own now. Refer to Chapter 23 for a more detailed discussion. Blah, 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 blah. Evaluation. Evaluation of the care plan is essential for patients who are potentially angry and aggressive. A well-considered plan has specific outcome criteria. Evaluation provides information about the extent to which the interventions have achieved the outcomes. Revision focuses on all aspects of the nursing process. Was the assessment accurate and thorough? Were the nursing diagnosis applicable to the assessment data? Did the nursing diagnosis accurately drive nursing interventions? Was the plan comprehensive and individualized? The initial plan may have included assessment of the environmental stimuli that precede a patient's agitation. Once these are identified, the plan provides an intervention specific to those stimuli. However, the plan can work only if staff members evaluate the effectiveness of the approach by noting the extent to which agitation is decreased. Evaluation may reveal that the patient's agitation has decreased except in specific situations. You then revise the plan to include these situations. And that is it for this chapter.